Hello everyone, it's Dr. Locklear here, and I'm coming to you today with Module 17, Perioperative Care or Perioperative Nursing. It starts on page 1387 in your textbook. And so what we're going to be looking at here, as you can see from the picture on the PowerPoint slide, we're talking about the nurse that works in a operating room or some type of surgical setting. And these nurses have completely different roles than nurses on the regular floor and units in the hospital type settings or other settings as well. And as we go through this, you're going to see that there are three phases to the operating nurse's role. We're going to be talking about the preoperative period, which is before the surgery, intraoperative, what the nurse does during the surgery, and then the post-operative nurse, and what does that nurse do. So let's get started. So we're going to look at what is the scope of practice of the perioperative nursing in the three different phases of the perioperative role. What is the relationship between the perioperative care and other concepts? And as you see in your textbook, if you'll look on page 1393, you will see the concepts of assessment, comfort, infection, oxygenation, perfusion, stress and coping. All of these are affected during the surgery. We're going to talk about the process of the perioperative nursing, the intraoperative nurse, and the postoperative nurse. And we're going to look at cultural and considerations through the lifespan as well. So what is the concept of the perioperative nurse? It is the term used to describe the three phases of the surgical procedures: the pre-operative phase, the intraoperative phase, and the postoperative phase. So, what is the preoperative phase? It is the phase preceding surgery in which the patient is identified as a candidate for surgical or procedural intervention. So the person goes to a doctor, a surgeon, or just a regular doctor, and they're like, oh, you need surgery. So all of this happens during pre-op. So during this preoperative phase, the patient is assessed and prepared for surgery. This includes, but not limited to, lab tests like blood work, medication administration, and physical assessment. They may also have to have chest x-rays, CT scans, whatever the physician thinks that they need ordered. And the intraoperative phase is the actual surgical intervention phase. So this is where the surgery takes place. During this phase, patients are put under anesthesia, so they're put to sleep. Using different methods, you can be under general anesthesia or light sedation, just depending on the nature of the surgery that you need. And so they are, during the pre-op, they talk to the anesthesiologist and they want to gather information about have they ever been intubated before? Have they ever been put to sleep before? How did they tolerate that? And so during the intraoperative phase, you will see that they may have to go through the process of being intubated, and that's of course where the endotracheal tube is inserted and they are mechanically ventilated during the procedure. They're also prepped, so they may have to have surgical sites cleaned with chlorhexidine or whatever that particular facility uses at that time. They go through a process where they're draped, where they drape the surgical site. And the surgical procedure, of course, takes place during this time. On completion of the surgery or the procedure, the patient's stable and breathing effectively, the patient is prepped for the post-op period. So once the surgery is over, they go to this period called the post-operative phase, and this is the recovery phase. So at this point, once their breathing looks good, their O2 sats are good, they maybe starting to arouse a little bit, respond to touch and sound, they will start the process of extubation or removing the endotracheal tube. The postoperative phase is the recovery phase. It begins with the patient leaves the surgical suite and continues until patient meets all discharge criteria. and that means discharge to the unit itself. Post-operative nursing care is tailored to meet the patient's specific needs. So, they've had surgery, and you want to be able to meet the needs of somebody that's going, through the surgical procedure. I mean, you lose blood, you've been put to sleep, so your oxygenation and perfusion are definitely affected. You are experiencing pain after surgery. So a lot of things have to be monitored: heart rate, blood pressure. Your blood pressure can drop because of perfusion issues. A lot of monitoring, a lot of assessing and reporting during the surgical procedure. Considerations that shape postoperative care include the specific procedure performed and the patient's response to the procedure. The type of anesthetic used, so was it light sedation or heavy sedation, because it's going to take them longer to wake up, it's going to take longer for their bowels to wake up. And the patient's response to the anesthesia. I know for myself, I don't do well with anesthesia. Sometimes I don't wake up till the next day. So some people just will sleep and sleep. They don't wake up very quickly. It gives you some examples here. It says nurses working in like a dermatology office are less likely to assist with the removal of certain cancers using surgical procedures that generally involve local anesthetics. So of course in local anesthetics, this person's not put to sleep. In pediatric offices, nurses may be required to provide nursing care for patients with minor wounds like getting sutures. In a medical surgical unit, post-operative care it occurs like when you've had certain surgical procedures, removing your gallbladder, or hip surgery, or a biopsy, or saying some people have to go to ICU because they're not stable enough to go to the med-surg unit. Labor and delivery nurses provide post-op care for the mom and the baby, especially if they've had a C-section. Because of its applicability across settings and across the lifespan, and because of the risk involved, surgical nursing care is related to a wide variety of concepts in nursing, and I've already mentioned those concepts, and we will cover those again. So who is the surgical team? So on page 1388, it talks about the according to the Association of Perioperative Registered Nurses, or the AORN, the perioperative documentation should include all steps of the nursing process, including assessment, diagnoses, identified outcome, planning, implementation, and evaluation. So OR nurses have to be very sharp in their ability to assess and use the nursing process. So who's on the team? The surgeon performs the surgery. The anesthesia personnel, these are the ones that administer anesthetics. It can be a medical doctor, which is an anesthesiologist, or a certified registered nurse anesthetist, CRNA, or anesthetist assistants, and they put you to sleep. The preoperative nurse, they care for the patient before surgery. Circulating nurse cares for the patient during the surgical event. The surgical technician passes surgical instruments and supplies, and this doesn't always necessarily mean it's a nurse. It can be a surg tech person that's been trained to do that, but some surg tech are nurses. First assistant assists the surgeon with the techniques of the surgery, and the post-operative nurse cares for the patient after the surgical procedure. You also may have somebody to help interpret if there's a language barrier. A hospital liaison advocates for the patient. A nurse navigator provides assistance to help overcome barriers in the healthcare system. Somebody may have to come for radiology and take x-rays right while they're in the OR. Specialty physicians, they play a role in the patient's surgical care by offering to help with their specialty area. The respiratory therapists, they assist in maintaining the patient's airway. Again, most of the time, if you're under general anesthesia, you're intubated. Social worker, of course, helping to follow up with discharge planning. The wound care nurse, or your WOCN nurse, and then other additional people on the team. And that's on page 1388. So, perioperative diagnostic test. So, what are we looking at? Look at table 17.1 on page 1389, and it gives you a variety of different types of tests that need to be done. A PT, we need to know if their blood's able to clot in an appropriate time frame. If a lot of times if you're on blood thinners, you have to stop them 7 to 14 days before you can go to surgery. Even an aspirin has to be stopped. Hematocrit, hemoglobin, red blood cells, platelets, all of these relate to clotting of your blood. Your sodium, because of perfusion, sodium's in our blood, and we have nausea and vomiting, and we can lose sodium that way. Same thing with potassium and pH. Your CO2 and your HCO3, which is your bicarb, these are all related to respiratory. So, we want to make sure that the patient is breathing and that they are having appropriate oxygenation through perfusion. Perfusion and oxygenation always go hand in hand. Are they pregnant? The HCG test. The protein, we're looking at their kidney function, their glucose, because a lot of times people are NPO. They can't have anything to eat or drink after midnight before they go to surgery. And if they're diabetic, it definitely affects their blood sugar. What to check the BUN and the creatinine, because again, that looks at kidney function. Chest x-ray to rule out any respiratory problems such as pneumonia and things like that. EKG, we want to make sure that their heart rate and rhythm is strong enough and appropriate enough to be able to tolerate surgery. Some folks, are old and elderly and they may not survive going through surgery. So perioperative safety precautions. So when you're looking at the AORN, the American Society of Para-Anesthesia Nurses, which is the ASPAN, and the World Health Organization, they created guidelines and safe practice recommendations for perioperative staff to utilize during the care of the perioperative patient. The Joint Commission established a universal protocol, and so what they did was they created these guidelines for healthcare professionals, and they're designed to prevent errors during the surgical procedure. So in other words, some checks and balances. Each of these organizations emphasizes the need for pre-procedure verification processes, timeouts, and handoff reports. And so, we want to make sure that we prevent what's called a never event from occurring. Never events are surgical errors that should never occur, such as amputating the wrong leg, as an example they give you. A pre-procedure verification process is a standardized process used to verify that the correct procedure is being implemented on the correct patient on the correct site. Name and date of birth. What kind of surgery are you having today? Where are they operating? They'll mark it with a pen. They'll ask you that over and over and over, and they should ask you that. A timeout is a momentary pause and accuracy check taken by all members of the procedure team before an invasive procedure begins. And they'll go back through all this. What's your name and date of birth? What are their allergies? What procedure are they having done today and where? A handoff report is a standardized communication process. It captures all essential patient information for healthcare providers who are exchanging responsibility for patient care. To ensure accuracy, handoff reports frequently follow standardized formats such as your SBAR. And so you want to tell the situation. What's the patient's background? What was your assessment and what are your recommendations? Healthcare facilities take these national guidelines and recommendations into account when creating protocols and policies for the perioperative staff to follow. And again, using the SBAR, you cannot go wrong with the SBAR process. You want to make sure that, you're doing these checks and balances, time out, and they do times out during the surgery too, and they'll count the number of sponges. They count the number of sponges that they put out, and then they count the number while they're operating, and they count the number again after surgery, because sponges and surgical instruments have been left inside of patients before, and it causes a lot of problems, and they have to go back in and open them back up and take it out. So you have a pre-procedure verification process. Look at table 17.2. So preoperative nurse, circulating nurse, the anesthesia team, and interpretation services. Correct patient, correct surgical procedure, correct surgical site marked by the surgeon, review of the labs, medications, allergies, health history, diagnostic tests, and abnormal labs, and is the informed consent signed, and has the patient been explained the procedure. That is imperative. The intraoperative phase is the entire surgical team. Prior to initial surgical incision, change in surgeon and/or change in position, name of patient, date of birth, consented procedure, informed consent, allergies, antibiotic administered. A lot of times they'll do antibiotics as a prophylactic to prevent a possible future infection. Apply applicable implants, radiology records present and in the room, because they can put them up on the x-ray and see while they're doing the surgery. Surgical prep is dry. On conclusion of the surgical procedure, again, the name of the patient, consented procedure and actual procedure completed match. They all match. All the information matches. All specimens acknowledged and approved by the surgeon. Surgical instrument and sponge counts are correct. Like I said a while ago, they go, they make sure that they count. And then post-operative. And this is your PACU nurses, circulating nurse, anesthesia team, and again, interpretation services. Name of the patient, the surgical procedure completed, type of anesthesia, surgical site, drains, implants placed, review of pertinent history, medications, allergies, health history, abnormal tests, and surgical complications. Look on page 1391. And it says the AORN focuses on 6 phases of medication use: procuring, prescribing, transcribing, dispensing, administering, and monitoring. And so they're really going through these safety practices during medication prep and administration, because you don't want them to have an allergic reaction while they're on the table. Recommendations include, but are not limited to, the perioperative nurse being mindful of the 7 rights of medication administration. And in the current ATI pharmacology book that we use at RCC, they have 10 rights of medication pass. Continually assessing the therapeutic and adverse effects of the medication being administered. The Joint Commission, additional guidelines that a perioperative nurse should follow to ensure safe medication practices include adopting the 2-patient identifier method during the preparation of medication, before administration of meds, utilizing standard abbreviations, because we don't use a lot of abbreviations anymore. We've gotten away from that. We want to make sure that people are able to read what it actually says. And most lay people don't know what these abbreviations mean like we do. The Joint Commission also recommends labeling medications and solutions when preparing for administration, especially if the medication is handled by multiple people. The nurse should follow these recommendations and guidelines in all 3 perioperative phases. The 2-patient identifier method requires nursing clinicians to identify the patient and match the treatment to the patient using 2 methods of identification. For example, the nurse may identify patients by asking them to verbally identify themselves by name and date of birth, and by comparing the name and birth date given with the patient's wristband. These 2 identifiers are compared to the medical order, which should match both identifiers. And these are part of our national patient safety goals as well. We have to use those patient identifiers. We, again, with medications, getting the medicine, getting it from the pharmacy. Is it prescribed correctly? Did the pharmacy dispense it correctly? Was it administered correctly? And are we monitoring? Remember, when we give medicines, you are responsible for monitoring the effects of that medication and reporting any side effects or adverse effects. And again, the ASPAN adopts the two patient identifier method. And be careful with abbreviations. Only use approved abbreviations from your facility. That's very important. Common medications administered to patients undergoing surgical procedures include antibiotics to control nausea and vomiting, non-opioid analgesics pre and post-op to control mild to moderate pain, and opioid analgesics intra or post-operatively to control moderate to severe pain, antibacterial drugs to decrease the risk of surgical site infections, anxiolytics to help with the anxiety, and of course general anesthetics as well. And so, when these medicines are ordered, they will again look at the patient's history, the physical assessment, the systems involved, and we've got to do ongoing assessments of this patient. We don't have the luxury of not. Post-op nurses, intraoperative nurses, they monitor and assess and they report. You monitor, assess, and report your findings. Again, here are some of the common medicines listed on this slide as well. Concepts related to the perioperative care. The concepts are listed on page 1393. And as you can see, assessment. So we need to do a thorough assessment. Nursing care during the perioperative period begins and ends with an assessment, consistent and constant reassessment. Comfort. What kind of pain are they in? Are they anxious? Do they need pain medicines? Do they need anxiolytics? Antihistamines to help dry up secretions. What's the developmental age of this person? People at different ages respond to pain different ways. Infection. What would you see if a patient possibly had some infection? Their white blood count will be up, of course. They may run a temperature. Their heart rate may be up. They may be complaining of pain at the site. Perfusion. What does their skin color look like? Are they getting enough blood to the vital organs? Again, perfusion and oxygenation. This affects their respiratory status. The more sleepy you are, the less you breathe because your body's relaxed and you may not get enough oxygen in. And if we don't have enough oxygen, we don't have enough oxygen in our blood. Even if we are having a good circulation going on, there's not enough oxygen in it sometimes. So we need to be aware, of heart rate and blood pressure and skin color and oxygenation readings, your O2 sats, and then stress and coping, because we know that, having surgery can be very stressful. It can be a scary time. It can be a time of uncertainty, and it can be a time of, just not knowing what's going on. On page 1391, it talks about concepts related to perioperative care, and I'm trying not to make this presentation too long because this is a long chapter. I'm sure this is going to be over an hour long, but please read page 1391 through 1393. It gives you some more detailed information about the concepts. And it talks about culture and diversity. People from different walks of life and different cultures handle things differently, and we need to honor, how they handle difficult situations like this. On page 1394, it talks about pre-operative nursing, and this is where patient teaching comes in. And you have a nice box on page 1394 that talks about preparing the patient for surgery. And I'm not going to read all this, but I do want you to read it. It's preparing the patient begins with the patient is identified as needing surgery. So I'm at the surgeon's office. and the surgeon says you need surgery and this is why, and they should walk you through the surgical procedure. Some surgeons will draw pictures. They'll ask you 2 or 3 times, do you understand? Can you repeat back to me what kind of surgery you're going to have? And some people can't. They may need somebody there with them to help them understand. You have to use a variety of nursing interventions and teaching styles. Nurses provide early patient teaching and reinforce preoperative instructions related to certain things. Blood thinners, you may be getting a Lovenox after surgery to keep you from getting blood clots, wearing SCDs to prevent from getting blood clots. You may have to stop the blood thinner 7 to 14 days before you have surgery. Tricyclic antidepressants, how are they going to affect the medications, the anesthesia? Herbal supplements, supplements that can cause bleeding and things of that nature. Teaching deep breathing and coughing exercises, teaching them how to take a deep breath, hold the pillow up against their stomach and cough, and how to use an incentive spirometer. Pain control, prevention of clot formation, wearing those compression stockings, wearing the SCDs, getting up as early as you can to walk. So please make sure that you focus on that. So patient preparations depend on certain things. So perioperative nursing begins immediately when a patient's notified the need of surgery. Nurses employ therapeutic communication to educate the patient about the upcoming procedure and to assess the patient's health history and current physical status. And you may have to repeat it several times and ask the patient to repeat back to you what you just taught them. And this teaching box here gives you great information on the things that we need to teach our patients. Right here, NSAIDs. Can you take NSAIDs? They increase bleeding. We need to teach them that because some people do take NSAIDs. Maybe they have arthritis or something. Patients preparing for surgery often need to participate in preparations that are specific to the surgery being performed, the site of the surgery, and the post-operative recovery. For example, abdominal, colorectal, or pelvic surgical procedures may require bowel preps. So you may have to take something to clean the bowel completely out, which patients complete the day before surgery. The nurse should provide the appropriate education on how to actually take these preps and what you have to do after the procedure's over. The nurse should provide informative answers if the patient has any questions. The preoperative nurse reviews all the surgical documents, such as the surgical consent, and we need to make sure it's signed. We go over it with the patient. Now, we're not allowed, it's out of our scope of practice, to tell them what kind of surgery they're having and the side effects and the risk factors. That's the physician. You just make sure the consent sign. Ask them, do you understand what the doctor told you? If they don't, you call the physician back and say they need to talk to you, they don't understand their surgery. The nurse should notify the surgeon that the patient needs additional information. The preoperative phase also provides time for the preoperative nurse to establish a level of trust and confidence with the patient, which helps with anxiety. Because, again, having surgery, well, if you're a cancer patient, you've just been told you have cancer, and now you've got to have your breast removed. That is a scary thing to go through. And so, we have to really be there for that patient. Nursing assessment, accurate and complete preoperative assessment is critical to ensuring that the patient receives a good outcome during and after the surgical procedure, because we need to report these things to the physician. A patient who is scheduled for surgery will experience anxiety. It is essential that the preoperative nurse use communication to establish trust and use a caring attitude. This will assist in decreasing anxiety and lead to a positive surgical experience. Begin by introducing yourself. Clearly explain what you're going to do and why you're going to do it. After that, get to know your patient. Use open-ended questions. What do you do for a living? What do you have? I don't have that problem. I really have the gift for gab, and I've always been able to talk to patients. I had a patient one time that said, "What are you so happy about?" Because they had, they were in the hospital and sick, and don't take it personally. And I said, well, I'm just happy to be alive and, able to have a job. And I just kind of blowed it off, as that kind of thing. And so, you got to understand they're not lashing out at you because they're mad at you. They're mad at their circumstances. They've been told bad news and sometimes. And so on data collection, you got table 17.3 on page 1396. Allergies, any previous surgeries, personal family history with anesthesia, hearing aids, glasses, and contact lenses, which sometimes these have to come out. Loose teeth, crowns, caps, because we don't want them swallowing any of that. Pacemakers, prosthetics, NPO status. A lot of times it says up to 8 hours before surgery. It just depends on the type of surgery that they have. Some say 6 to 8 hours, some say 4 hours. And one thing I'm going to plug in here is children. Children, if they're on the schedule for surgery, like your ear, nose, and throat doctor, because they see adults and children, they're going to do the children first. The more younger they are, they'll get done first because they need to get their formula and get their bottles, and they can't go all day without eating like we can. Culture assessments, your venous thromboembolism assessment, and communication assessment. Please make sure that you read over that. Again, it's a lot of information, and I don't want to make this lecture no longer than it has to be. But, I want to point you in the right direction on what you need to read here as well. The physical exam. The surgeon and the nurse are both responsible for completing a full physical exam. You need baseline assessment to provide background that will enable nurses to discern physiological changes during the preoperative period. The procedure team reassesses any component of physical assessment when there is an apparent change in the patient's baseline. I went in one time to have some ear, nose, and throat surgery, and when I got there, I had a fever of 102. They didn't do my surgery. They canceled it, gave me an IV dose of antibiotic, and gave me a prescription for antibiotics, told me to follow up with my ear, nose, and throat doctor, and I had to have the surgery at another time. Because if your body's compromised, then putting you to sleep is going to make you even more compromised. A psychosocial assessment. What is their stress level? How do they cope with things? You have an opportunity to assess and see if this patient's been abused, or if they're in a bad situation. Certain questions that you want to ask. How are you feeling about the surgery? Do you feel safe at home? Do you have any concerns? Do you have anyone to assist you when you go home? Do you have any cultural or religious preferences? The nutritional assessment, we need to know if they're a diabetic. We need to know that they understand that they can't have anything to eat or drink at a certain time. The preoperative nurse often performs the patient's nutritional assessment, which determines certain outcomes during and after surgery, including post-operative healing of the wound. For example, patients with a high body mass, or BMI, are at increased risk for poor wound healing because they have more adipose tissue. Perioperative nutritional assessment includes their weight, their body mass index, food preferences, and their total protein serum levels, because these protein serum levels will help determine if they've got a good chance of healing appropriately. We need protein to help with the healing process. The pain assessment is throughout the entire process, pre-op, perioperative, and post-operative period. And you may want to use a scale based on the patient's age. And of course, we can use the 0 to 10 scale, or we can use the Wambaker Faces scale, and your text talks about both of those. During the assessment phase, we want to look at the medication review. And this is really important because it gives you some detailed information on page 1397. And there is a box on page 1395 that talks about over-the-counter medications such as vitamin E, ibuprofen, and aspirin. We can get these without a prescription, and some of these cause bleeding problems. Herbal products can also have anticoagulation effects. Black cohosh, ginkgo, garlic, ginger, all these can lead to bleeding. Ginseng and licorice can elevate your blood pressure. St. John's wort have been known to increase and interfere with the effects of anesthesia. And I've actually had many students over the years tell me that there was a St. John's wort question on NCLEX. It also talks about other medications like high alert drugs. And so these would be your beta blockers. These are your heart medications, your blood pressure medications, anticoagulant medications such as warfarin, Coumadin, which place the patient at risk for increased bleeding. Medications delivered through skin patches, nicotine, estrogen, fentanyl for pain. The nurse should also inquire about the use of over-counter medications. And again, that box on page 1395 talks about that. And, you know, lots of medicines can cause adverse effects with many things. We need to know what they're allergic to. Bleeding is a major issue because they're gonna make an incision, and you're gonna lose blood once they make this incision. And once they make that incision, if you have issues with clotting, you could bleed out during surgery, and they definitely don't want that to happen. Informed consent. The patient is required to give informed consent. You can't do surgery. Now, I know you're probably thinking, well, what about during an emergency situation? They come to the ER and they've been in a massive car wreck. There are guidelines and protocols, for different aspects of different situations. But informed consent for scheduled surgery has to be done. The nurse, our role is to verify the signature that it has been signed and somebody has witnessed the informed consent. It is required for the procedure, administration of anesthesia, and blood products. You have to have informed consent. Patient consents to financial responsibility, photos, who has access to their information. They may have to sign a HIPAA form. And so, you've got many things that has to be signed. Part of our scope of practice and our job is to make sure that all these documents have been signed. The patient has been asked, did somebody come with this document or this document? If it doesn't show a signature, we can't send this patient to surgery. I've seen surgeries canceled because informed consents were not signed and they were supposed to be signed. And so it can really cause a delay. And, we have many checks and balances in the preoperative phase. You've got to check these forms. And when the nurses come from the OR to pick up the patient, they'll go through the chart with you one more time before that patient ever leaves the unit. And they'll come in and talk with you as well to make sure all of these documents have been signed. Lots of documents in the OR. Preparing the surgical site. Before we move on to there, on page 1397, it talks about focus on diversity and culture and overcoming the language barrier. And, we need an interpreter. Nurses and other members of the healthcare team are frequently placed in situations with cultural and language barriers. You really need an interpreter. I know some, family members want to interpret, but we really need a professional interpreter. You need to follow hospital protocol for that. You shouldn't depend on a 14-year-old child to relay this information to their parent. We need a professional interpreter. Preparing the surgical site, and we may have to do this ourselves before the patient leaves the unit. It gives you an example here. The patient's hair around the surgical site should be removed only if there is a risk that it will interfere with the procedure. Hair removal should occur outside the operating room using clippers, not a razor. The surgeon may prescribe that the skin around the surgical site may be scrubbed using antiseptic soap. We used to shave everybody, and now they've got some different protocols in place for that. So preparation of the surgical site may begin the day before with instructing the patient to bathe or shower using a specific type of soap or the skin antiseptic. Preoperative showers help to remove these microorganisms, and they use special pre-packaged packs of wipes now to do that. We also use these wipes for people that have central lines and ports and things like that. Preoperative nurses either oversees or assists with preparation of the surgical site on the day of surgery. And then preoperative interventions. So you want to prepare the patient for surgery, do everything you can to make sure everything has been done, because this saves time. It's just like I said, if the consent's not signed, the surgery is going to be canceled. Can include patient teaching related to the post-operative care, and we do that in preoperative. Post-op teaching, get this, occurs in the pre-op phase, such as how to turn, cough, and deep breathe, how to ambulate safely, how to use the incentive spirometer. And I'm pretty sure you were probably told this during fundamentals, but with the incentive spirometer, one good way to teach them is every time a commercial comes on TV, use your incentive spirometer, because they show commercials every 10 minutes, and you should use your spirometer 10 times per hour. That's just a good little way to remember. Preoperative documentation. And so when we're looking, there's a box on page 1397, preoperative documentation, history and physical, social assessment, nutritional assessment, the head to toe assessment, that's number 4, pain, medications administered in the pre-op, and perioperative care plan. And we need to follow that plan of care. You, as a preoperative nurse working on a surgical unit, need to know that you have all these forms that you have to thoroughly go through and make sure all of this has been done. And there are pre-op forms that you have to fill out in the computer. You don't just have to say, well, where does this go and where does that go? You do have preoperative documentation that you have to do. Okay, now we're moving to the second phase, which is the intraoperative nursing period. And so this includes all aspects of a surgical or invasive procedure within the operating room or procedure room. Constant monitoring of both the surgical environment and the patient is necessary to ensure patient safety. The intraoperative environment is a high-risk area because the patient's exposed. They could get, exposed to infection. Most operating rooms, they're cleaned thoroughly. The ceilings, the walls, equipment, everything is like scrubbed down immaculately after every surgery, and it's kept cool because we know cooler environments help keep the bacterial counts down. The intraoperative area, again, is very high risk. They're at risk for infections, surgical areas, wrong site surgery, retained instruments sewed back inside their body, burns from equipment used to cauterize, and incorrect specimen labeling. So, a lot can happen. Having surgery is a very high risk area. And so, what are the types of surgery? You see on page 1398, it lists the types of surgery, and I'm not going to read over those. You can read over those yourself, but it does give you 2 terms that I want you to know. Ectomy, which is the removal of an organ, such as a cholecystectomy, that's a gallbladder removal, and then oscopy, the part of the body is being viewed through some type of scope, and I tried to give you a picture there of that. Other types of surgical procedures, and here's just another list. Reconstruction, like when you've had a double mastectomy or and they're going to do reconstruction and put the expanders up in there. But look at these. Now, emergency surgery is surgery that's got to be done right then, and that's what I was talking about earlier. There's different guidelines for that. Okay. Length of surgical procedure. This depends on the type of the surgery. Longer procedure times are associated with an increased risk of complications. Shorter procedures benefit patients of all ages. The longer the procedure, the longer the patient is exposed to the anesthesia, which causes a longer recovery time. Again, like I said, when I've ever been put under a general anesthesia, I didn't wake up to the next day. I've even had them tell me before, we didn't think you were going to ever wake up. The longer the procedure, the greater risk of hypothermia, which can increase the time required for healing. The patient must maintain normothermia, or normal body temperature, because remember, it's cool in there and your perfusion is affected, and our perfusion helps regulate our body temperature. So, the longer you're asleep. Procedures that last 30 minutes or longer places the patient at risk for thrombosis or thrombotic embolisms, blood clots in the legs, basically. Patients may be required to wear your sequential compression devices, or your SCDs, to prevent the VTE. Follow your facility's policy. And again, this is where you may have to have a Lovenox. Most people that have any type of procedure done, unless they're compromised, gets Lovenox after the procedure. The longer the procedure, the greater risk of blood loss. And so that can lead to a blood transfusion. And we know that, losing blood volume can cause us to go into shock. It can shut our kidneys down. It can affect our heart rate, our blood pressure, our oxygenation. And so the patient may have to have a blood transfusion. Some people may not be able to have a blood transfusion because of blood incompatibilities. Sterile field and hand hygiene. In this area, this is where we're in the intraoperative area, and this is where we've got to do the surgical scrub. You do that hand scrub according to the healthcare facility's policy and to their guidelines, and it is outlined in your AORN guidelines. Recommends a 3 to 5 minute surgical scrub before donning sterile gloves to reduce. Notice it says reduce. It doesn't say it gets rid of all of them. You will still have some germs on your hands. Hand hygiene should also be performed on completion of the surgery and whenever surgical gloves are removed. And the surgical gloves may have to be changed during the surgery. Before and after eating, before and after using the restroom, and when hands visibly soiled, before and after caring for a patient. I know personally for me, I'm not crazy about the hand sanitizer. Especially when I've been in a patient's room, I want to wash my hands. During surgery, responsibilities vary according to the procedure, and so whatever role you are fulfilling, that will be your scope of practice for the duration of the surgery for that patient. Continuous surveillance. The perioperative nurse must maintain continuous surveillance within the intraoperative setting. The nurse acts as the substitute for the senses temporarily lost by the patient. So in other words, we are the eyes and ears for this patient. They're asleep. They may respond to you verbally, but they're not with it. They're still under the effects of the anesthesia. Nurses are taught that they are patient advocates. In the operating room, the patient is unconscious, and the circulating nurse becomes the protector of the patient. To be comfortable being the spokesperson for the patient, the perioperative nurse needs to have self-confidence. You need to be able to know when you need to speak to a physician. The nurse needs to be able to relay this confidence, and this comes with experience. The nurse will learn the sounds of the operating room, such as the noise made by the anesthesia monitors and the conversations between the anesthesia team and the surgeon. Nurses learn by experience to recognize changes in the patient's heart rhythm, a change in blood pressure, or even a drop in oxygen saturation. The circulating nurse vigilantly monitors intraoperative events, including the patient's volume of blood loss and other safety-related concerns. The nurse begins to learn these skills in nursing school and builds on them through gaining experience. So you do, as a circulating nurse, a lot of monitoring. Intraoperative safety precautions includes many dangerous combinations for both the patient and the healthcare team. Again, I can't stress this enough. Having surgery is a very high-risk area. You have the chance of dying. There's no guarantee you're going to make it through surgery. As my slide shows here, safety first, surgery checklist. Make sure, that you are following procedure. We want to make sure that the patient has a successful surgery. Table 17.4 on page 1400 and 1401. Well, that's 17.5 table, and that's your positions. But 17.4 is your intraoperative safety precautions, and it talks about if a patient's getting electrical method used to cut and cauterize. It talks about using lasers and different chemicals. Please read over that, because if I read all of that, this lecture would be 2 hours long. And so make sure that you look at table 17-4. Fire in the operating room can have devastating health consequences for the patient and procedure team. Before the operation begins, make sure to place the grounding pad and all electrosurgical equipment correctly to prevent injury from burns or fire. If using alcohol-based skin antiseptic, ensure the skin is completely dry before putting the surgical drape. And this grounding, you got to make sure that everything is grounded correctly, or you can cause an electrical fire. Surgical procedures often use electrosurgery machines that use electrical current for cutting or cauterization. During the preoperative nursing assessment, the nurse should inquire whether patients have any metal in their body. If so, the preoperative nurse must alert the surgical nurse because of the risk for injury to the patient if electrical current comes through. So we need to know anything that affects electrical current, because it could shock the patient and the people working in the surgical area. Positioning, and this is so we have access to the surgical site. And on page 1401, it gives you the surgical positions, and it goes over to page 1402. So depending on the type of surgery, and I would read over this, depending on the type of surgery, they're not just going to lay you on your back for every surgery. You may have to have different positions, like the prone and jackknife position, or the lateral position. That may be for a patient that's having hemorrhoid surgery. You got to get to their backside, okay? So joints, nerves, and skin must be protected during movement and final position, because remember, these people are asleep. So, they may be able to help get on the table once they get into OR, but once they give them their full anesthesia, they're out, and you're the one moving the patient. Padding used under pressure points to prevent nerve injuries and protect skin. This is extremely important for the patient. Look on page 1403, it's talking about the lithotomy position. Said both legs need to be lifted and positioned in the stirrups at the same time, or the patients can their hips can potentially be dislocated. Older adults are at greater risk for development of pressure injuries. The nurse positioning the patient must take care to check the appropriate pressure points of the position and to provide padding as appropriate. And then it talks about your anesthesia on page 1403, and it gives you a good box. Local anesthesia, the patient's usually awake. Conscious sedation, the patient's not intubated. Propofol is usually used, or fentanyl, and the patient can talk to you, but they won't remember it. And then general anesthesia, this is where they're intubated, and they will intubate you before you go into the surgical procedure itself. And so you have to teach them, what to expect after they've been intubated, because they're going to have a sore throat. How do you treat that sore throat? And then it talks about the ASA physical classification system. As the ASA level is not used to estimate the possibility of anesthetic complications, nor does it dictate the type of anesthetic that will be administered. The ASA classifications are as follows. And this, this is the American Society of Anesthesiologists, and they have this classification to go by, so to make sure that, they're giving you the right amount of anesthesia according to the level that you are. And it goes 1 through 6. The patient is healthy, that is free of health conditions or systemic disease. Number 2, the patient demonstrates mild systemic disease, obesity, uncomplicated diabetes, and so forth. Number 6, the patient is brain dead but may be an organ donor. Okay. And then it talks about the different ways of being intubated and the types of equipment that they use, endotracheal tube. And it gives you some good pictures here of the different types of tubing that they use. And so the laryngeal mask airways, anesthesia providers chooses airway management devices. It's inserted into the pharynx, forms a seal around the laryngeal inlet, creates positive pressure ventilation, and then the endotracheal tube is inserted through the vocal cords in the trachea. And so, of course, that's why you have such a bad sore throat. And these are put in by people who are trained. A registered nurse does not do that. And then surgical site preparation. This occurs just before the sterile draping of the patient, and they clean the site with these antibacterial agents to kill possible infections or reduce the number of microorganisms that can possibly cause an infection. Table 17.7 talks about the commonly used surgical prep solutions, and you have povidone, iodine or betadine, and then chlorhexidine and Betaset, surgical scrub. And so a lot of these are alcohol based, and we know alcohol is a good agent for killing microorganisms. And then your surgical safety checklist. Again, we've kind of already talked about this, and so it talks about your circulating nurses often charged with conducting the timeouts. And so they'll do the timeouts and say, okay, let's stop, let's count, let's, where are we? Give me an update on the patient. And then your intraoperative documentation. The circulating nurse provides thorough documentation and records all aspects of occurrences. So the circulating nurse is responsible for recording during the surgery as well. Other documentation for this particular role of the nurse. Look on page 1406, and it gives you some good information. I'm sorry, 1407, intraoperative documentation. And again, I want you to read through this for the sake of time. I'm already at an hour on this recording here, and I still have quite a bit to go. But handoffs, pre and post-op diagnoses, team members, I's and O's. I mean, just, the timeouts. Look at the list here. And there's, I hope when you get through reading this chapter and listening to this lecture and hearing this in class as well, you will understand how intense being an operating room nurse can be. And I don't know about you, but when they come and get me to take me to surgery, I want a nurse that is competent and that they understand every bit of what they're supposed to do for me while I'm in surgery. So please read over this, okay? Infection, aseptic environment. Of course, we've talked about that, keeping the OR clean, making sure that it's a cool environment, they're cutting down on the infection or the microorganisms that cause infection. And then surgical classification of wounds. And this is on page 1407, and you have table 17.8. Class 1 is clean. Class 2 is clean contaminated. No signs of infection, but the alimentary, respiratory, genital, urinary tract is entered under controlled condition. There is no break in sterile technique. Class 3 is contaminated, and this is where you have spillage from the GI tract. So you've got some contamination. And then class 4 is dirty. If there's a minor break in sterility, the wound class level increases to the next level. And so they go by this classification to predict the possible amount of infection that this patient may encounter. Potential intraoperative complications. Circulating nurse pays attention to the whole intraoperative environment. So being the term circulating, what do you think they're doing? They're circulating around the OR. They're not just standing in one place. This includes changes in the sounds of the monitors, like it said before, changes in the color and amount of urine. Has it gone from yellow to bloody? Are they losing blood through the urine? Sometimes as nurses, we fail to assess the patient's urine. And the urine can tell us a lot. And so you really need to look at that urine. Look on page 1408, table 17.9. It gives you potential intraoperative complications. Hypovolemia, low fluid volume. Hypervolemia, increased fluid volume. Hyponatremia, low sodium, and so forth. And it gives you the signs and symptoms to look for, like under hypovolemia. You're going to see an increased heart rate, increased respiratory rate, decreased urine, decreased blood pressure. Okay? Hyponatremia, we know that affects our muscles, muscle twitching. Hypokalemia, potassium, we may see cardiac dysrhythmias. You will see that more with hyperkalemia, though, than you will. Well, no, let me back up. Hypokalemia and hyperkalemia both cause arrhythmias. Let me say that again. Hypokalemia and hyperkalemia both affect your heart rate. The hypokalemia, low potassium, causes severe arrhythmias. Hyperkalemia causes arrhythmias. Increased intracranial pressure. Boy, this is a big one because the patient could die. They could die if their pressure goes up. Okay? And here's your list here. Please look at this table 17.9. Cardiopulmonary resuscitation. Surgery and anesthesia are associated with serious risk for all patients. In the event of a cardiopulmonary arrest during the preoperative period, the nurse should follow hospital protocol to call a code blue, in which a team comes, such as your rapid response team or your CPR team. If a patient deteriorates during the intraoperative period, the surgical and anesthesia team are the CPR team. Within the intraoperative and postoperative, a member of the healthcare team runs the code, and so you have a team running the code. And I wanted to show you this picture because I've seen rooms that look like this after a patient coded, and they got them from wherever they were to ICU on the ventilator, and it looks like a war zone. And I can tell you, if you've ever been in an intense code, and you will be once you get out into nursing, this is what you're going to see sometimes. It looks like a war zone because we are doing everything we can to save that patient's life. It talks about blood transfusions. It talks about autologous blood, and this is where patients can donate their own blood. And then patients can also receive blood that has been donated by the community, and this is called your allogenic blood transfusion. There's 3 methods of autologous blood donation: preoperative, normovolemic hemodilution, and perioperative salvage of autologous blood, and you can read about that in the reading. Post-op nursing. So now we're at the end, and so now the patient's had surgery and they're in the PACU. What do we do? So the post-op phase begins with admission to PACU and concludes upon transfer to wherever they're going. They're either going to be discharged home, ICU, or to a floor. Post anesthesia care unit is typically referred to as PACU. In more critical states, they may go to intensive care units, which is ICU. At the recovery, medical surgical floor, or discharged home. And they may go to ICU first and then to the med surg floor or a surgical floor. So it could be any of these, depending on the type of surgery. Your detailed handoff, again, this is imperative. And notice it says detailed, okay? You know, you have got to tell everything that went on with that patient. And one thing that's so important to report is the last time they got pain medicine and how much. Because most of these patients are getting morphine, some type of opioid, and we know that that can depress your respiratory status, and you don't want to give them another dose if, you know, you as the receiving nurse need to ask, you know, when was the last time they had pain medicine? How did they get it? How did they respond? And how much did they get? And it gives you a list here on page 1410. And so first of all, airway patency. Ability to protect the airway. Is oxygen saturation good? Are they breathing good? Are they able to come out of the anesthesia? Are they moving? Are they talking? Are their sensations returning? Are they breathing okay? The gag reflex. Has their gag reflex come back? And you'll see this a lot with people who have been put under heavy sedation. You have to check the gag reflex. Cardiovascular status. Is their blood pressure stable? Is their heart rate stable? Also under reflexes, don't forget about the cough reflex as well. Fluid status. Are their kidneys perfusing? Are their kidneys putting out urine? Because remember, I know you're thinking, well, they're NPO. They hadn't had anything to eat or drink. They got a bunch of IV fluids. And that's another reason you have to look at cardiovascular status and pulmonary status, because they're getting a lot of IV fluids, which can overload the system. Bowel sounds. Are their bowel sounds coming back? And it may take a 24 to 48 hours before their bowel sounds come back. It just all depends. Pain, nausea, and vomiting. We really want to keep that under control, because we don't want them vomiting to the point that they rupture their surgical site. Significant findings that must be reported immediately to the surgeon or anesthesiologist include prolonged unresponsiveness. You can't wake them up. Decrease in level of consciousness. They should be waking up. Oxygen saturation 92% or lower. Respiratory rate less than 10 per minute. Tachycardia or bradycardia. Hypertension or hypotension. Weak or absent pulses. Urine output less than 30 milliliters per hour, and bleeding more than expected at the incision site. And you should mark these incision sites. And that way, what I mean by mark it, put like a ink line around it. And if if that wound is actively bleeding, it's going to bleed past that ink mark that you drew. Again, here are some of your post-operative nursing diagnoses. These may include acute pain, of course, impaired gas exchange, anxiety, decreased cardiac output, and deficient fluid volume. Even though they're getting a lot of fluids, they still hadn't had anything to eat or drink. Okay? Risk monitoring. So what are we looking at when we're talking about risk monitoring? We want to look at what type of surgery they had. Certain surgeries, high risk for urinary tract infections. So a lot of patients get an indwelling Foley catheter. So you need to look for the signs and symptoms: fever, nausea and vomiting. The urine looks cloudy, sandy colored. It's dark. It smells bad. Strict I&Os. Note changes in appearance of the urine. Is it bloody? Again, is it very dark and amber color? Use of critical thinking skills. Use your critical thinking skills. Again, are they putting out 30 milliliters or more per hour? They should be putting out at least 30 milliliters or more per hour. The post-operative nurse must maintain IVs as ordered to replace body fluids lost as a result of the surgical procedure. Once oral intake is permitted, and they usually start with a liquid diet, clear liquid, and they will progress you. The nurse should offer only small sips of water. Anesthetics and narcotic analgesics impair mobility of the intestines, and large amounts of water may induce vomiting. If the patient cannot yet drink water, the surgeon may permit the patient to suck on ice chips. And that's one of your safety alerts. Cultural considerations, we've already talked a lot about that. We definitely want to incorporate their cultural needs and just read over that. Post-operative medications, it gives you a list here. These look like good test questions. Pain medications, not limited to hydromorphone, Dilaudid, very strong. Morphine, fentanyl. You can see medications in 3.1 in Module 3. Pain medications assist in lowering the patient's pain level and in turn decreases the elevated blood pressure and pulse. What happens to your blood pressure and pulse when you're in pain? It goes up. And then antiemetics to keep you from vomiting. Zofran is usually the drug of choice. It has less side effects than Phenergan. Phenergan causes major drowsiness and sedation, and your bowels won't wake up, and we don't use Phenergan a whole lot anymore. Airway. Most patients are extubated before transport to the post-operative care unit. Now, depending on the patient situation, they may have to go to ICU ventilated, but they won't go to the med-surg unit ventilated. If the patient's not stable enough to be extubated and remains intubated, again, they may be transferred to a critical care unit. Place patient in a sitting position if possible to decrease the work of breathing, and it helps them to decrease the chance of kind of choking a little bit on secretions and stuff. It says the post-operative nurse may have to perform a head tilt chin lip maneuver to open the airway or administer Narcan to reverse respiratory depression caused by narcotics. And so you need to monitor those respirations. If they're 12 or less, you need to look at your protocol and administer, especially if they've had morphine or whatever. And you need to call rapid response and need to call the physician, but you need to get that medicine in them. Cardiac rhythms. Patient receiving general anesthesia are monitored with an EKG upon arrival in the PACU. Post-anesthesia nurses all should have ACLS. It prepares them to recognize the various heart rhythms, causes for specific heart rhythms, and the course of action needed to return the patient to a normal rhythm or the patient's baseline rhythm before surgery. Depending on the patient's heart rhythm, post-anesthesia care nurses are trained to complete algorithms, including the administration of medications. For example, the patient arrives during the post-op phase and is placed on an ECG monitor. It shows that the patient presents with a pulse of 45 and demonstrates labored breathing. On the basis of this assessment, the nurse follows the bradycardia algorithm, including identifying and treating any underlying causes. The primary care provider who is directing the PACU should immediately be notified of any changes. If the patient goes into cardiac or respiratory arrest, call a code and follow your protocol. And then wound management. You may have sutures, such as you see here. You may have staples, and you want to monitor for signs and symptoms of infection, increased pain, bleeding, drainage, and make sure that the sutures are in place, the dressings are in place, and a lot of times the physician will not allow you to change the dressing until they change it first. Dressing reinforcement allows the initial dressing that was placed at the completion of surgery to create a pressure pack to the wound, which helps decrease bleeding. And I know a lot of surgeons like to change their own dressing, and you'll learn that. And then lines and drains. This is a picture of a Jackson Pratt drain. And what you do is you open it up and it'll expand, and you drain it and measure it. And then before you hook it back up, you squeeze it and then hook it back up, because that puts the suction on. If you don't squeeze it, it won't have any suction. But you may have IV lines, surgical drains, NG tube, wound suction, and make sure that you know what your order is. Is it continuous suction? Maybe they got an NG tube. Is that continuous suction or low intermittent suction? Some of these drains are to suction, like this Jackson Pratt drain. Leave the pressure dressings in place. Follow the doctor's orders for when they need to be changed. Suture, staples, and adhesives. Before I do that, let's look at page 1412. It also shows you a hemovac, and I didn't put a picture on here because there's a great picture here. But you see how you squeeze it out and measure it, and then you have to squeeze it to make sure that it has the suction. Note that the presence of bright red blood in drainage tubes or more than the expected amount of drainage in or around drains requires a report to the physician, because the blood should start to decrease over time, okay? And now you may have sutures and staples, and here's a picture of staples, and you want to know how many staples the patient got during the surgical procedure. You definitely want to include that in the handoff report. If any of them are loose while they're in PACU, you need to call the physician, because they need to come back and assess that. Because if they're loose and come out, then it could cause the wound to split back open. Other post-operative nursing care involves documentation, and we've talked a lot about documentation, and there's about 17.4. Now this is post-op. Again, review of the system, sedation, eyes and O's, blood administration, the dressing, the patient's level of consciousness, bowel sounds, oxygenation, respiration, blood pressure, perfusion. All of that is very important. In the patient recovery and discharge. And before we get to that, look on page 1413, and it talks about the Aldrich score. And I got a little picture here for you of how they scored, and it gives you a good explanation here. It says the Aldrich scoring system is designed to assess the patient's readiness for PACU discharge. So they follow this protocol, and look at the instructions at the bottom. The total score is 10. Patients scoring 8 or above, and or patients who are returned to a similar pre-op status, are considered fit for transfer to phase 2 recovery. So 8 or above. And so you'll have this protocol to go by, the Aldrich score. Again, post-operative nursing, we're still looking at patient recovery and discharge planning. If the patient does not meet the criteria, the patient's transferred to usually ICU for further monitoring. I've seen patients stay in PACU all night long, and the surgeons stay back there with them to make sure that they were stable. And look on page 1413. You got post-op discharge teaching. Use pain medications as ordered. Do not allow pain to become severe before taking the prescribed dose. Anticipate pain, and we can administer pain medicines 30 minutes before doing dressing changes to help with pain. Avoid using alcohol while taking opioids or other narcotics. Contact your primary care provider or surgeon if you experience an increase in pain. Change dressing and perform wound care as ordered. Promptly report an increase in redness, swelling, pain, or discharge. Gradually increase activities as ordered by the surgeon. adequate rest, nutrition, and hydration. And then there's a whole section here about nutrition and talking about, you know, you're not going to give them a full tray to begin with. You may start out with clear liquids, and then full liquids, and then soft foods, and then to a full tray. Physical activity, be careful because the patient's been under heavy sedation. They may be very groggy. They need assistance getting up to use the bathroom or to ambulate. They should not be allowed to get up by themselves. And then it talks about perioperative care of infants. Parents can help prepare. We definitely want the family involved. Again, like I said, children are going to be done first. And so please read over that section. The end of this chapter talks about lifespan considerations, and I'm not going to go through those. You can read those on your own because it's basically the same information that we've discussed in the post-op period, just some things are a little more specific to different age groups. So read through these. You've got perioperative care of the infants, perioperative care of children, pregnant women, and then of the older adult. Now you do have a safety alert, and so let's see. Here's your perioperative care of children. Okay, and again, you know, some of these things are the same thing as with any patient, regardless of their age or their situation. And there's care of the older adults. Look on page 1416. It said older adults are more vulnerable to postoperative infection than younger adults. Do not rely on the presence of fever to indicate infection in older adults. Patients in this population may have lower core body temperatures and decreased immune system. Signs of infection in older adults often relate to cognitive changes such as confusion or agitation. So in children, you may see fever, but in the older adult, it may be confusion. That is the key. And I added this slide, the National Patient Safety Goals for Surgical Patients. And when you click on this link, it actually takes you to the National Patient Safety Goal for surgery. It says this is done to make sure that each patient gets the correct medicine and treatment, identify patients correctly, prevent infection, improve staff communication, patient safety risks, prevent mistakes in surgery, use medicine safely, and use alarms safely. And this is some of the guidelines. And again, this link takes you straight to that.